disease. Varicose veins. Varicose veins are the most common vascular disorder affecting human beings. 10% of general population are affected by this disease. They have been described as any dilated, elongated, tortuous vein, irrespective of its size. Classification, either primary or secondary. Primary varicose result from intrinsic abnormality of venous wall. Secondary, due to DVT. Secondary varicose veins are associated with deep and superficial venous insufficiency. Classification according to size and shape: telangiectasia, reticular veins, and trunk veins. What are the risk factors? Combination of risk factors rather than one specific risk. Either hereditary or female sex, more common in female than male. Hormonal influence, gravitational hydrostatic force related to the job and occupation. Clinical manifestations. Patient with varicose is ugly looking, unsightly appearance. Pain, aching, heaviness, pruritus due to leakage and of RBC and lead to the dermatitis. Early fatigue of affected leg. Night cramp of the leg. Edema, thrombophlebitis, hyperpigmentation due to siderine deposition. Lipodermatosclerosis due to fibrosis and cicatrization, effect of extravasation of RBC into the interstitial tissue, and even ulceration and bleeding. Diagnostic evaluation of venous dysfunction. Prior to any operative treatment, patency of deep venous system and valvular competency should be determined by clinical and sonological tests. Perthes, Brody-Trendelenburg test are clinical tests using tourniquet to define the affected vein and competency of valve. Plethysmography, duplex Doppler ultrasound, these are used to see the flow of blood and patency or competency of the affected veins and perforators. Treatment of varicose veins. Indication of treatment: when you treat the patient with varicose vein by surgery or by conservative treatment. Symptom of aching, heaviness, and cramps. This patient needs treatment. Complication of venous stasis, such as pigmentation, as we said, due to tortuosity, stagnation of blood, there will be extravasation of RBC and destruction of RBC with liberation of substance, iron, that lead to the dermatitis, pigmentation, induration, superficial ulceration, and the thrombosis of varicosities. These are complications of varicose vein. Large varicosity is subject to trauma and rupture and bleeding, so it needs interference. For cosmetic cancer, because it is unsightly from cosmetic point of view and the patient seek for surgical advice. There are different types of surgery. This is what they call it stab avulsion, by delineation of the venous course by duplex ultrasound and different stab and avulsion of the affected vein. This procedure can be done for treatment. Second, high saphenous ligation, also after assessment, incision at or just below groin crease, medial to femoral artery, Venous centimeter, where the vein, artery, and nerve present in this from medial to lateral, femoral vein medially, femoral artery, and nerve. Van. So exploration of the saphenous opening by this incision, which is at or just below groin crease, and then ligation of tributaries, 3 tributary of the long saphenous vein, which are the external circumflex femoral vein and the superficial epigastric vein and external pudendal vein. These are identified and ligated, and then ligation of sapheno-femoral opening flush with the femoral vein and stripping of the vein. This procedure, high saphenous ligation. Non-surgical treatment of varicose. Conservative sclerotherapy using sclerosing agent to be injected within the vein to fade and the patient get relief. Use of elastic compression stockings. Periodic elevation of lower extremity. Exercise of leg muscle. احنا بننصح المريض sometime in case of conservative treatment to elevate his leg when he is or she is at rest, to decrease the load of blood column on the vein, using of elastic compression stocking or using bandage in multi-layer bandage to compress the vein and press the blood upward to decrease the load on muscle and decrease the pain, or periodic elevation of the lower extremity and exercise as well. DVT, deep vein thrombosis. Acute deep vein thrombosis is a major cause of morbidity and mortality in hospitalized patients, particularly in the surgical patient. Causes or etiology: 3 conditions described by Virchow, and this called Virchow triad, contribute to venothrombotic embolism formation, stasis of blood flow. First, so slow blood flow and slow circulation. Second, endothelial injury that line the vein. And third, hypercoagulable state. The last one, hypercoagulability state, is the most important spontaneous cause in DVT, whereas the stasis and endothelial injury likely play a greater role in secondary DVT after immobilization, surgical procedure and trauma. Hypercoagulability state, due to deficiency of certain factor responsible for anti-thrombotic activity, factor 5 laden mutation, prothrombin gene mutation, deficiency of protein C and S, hereditary, antithrombin 3 deficiency, antiphospholipid syndrome are the hypercoagulable states causes. Sequence of pathology: propagation to involve a proximal segment of deep vein thrombosis or deep vein system. This will increase to propagate into distal part, and sometimes showering emboli detached lead to the pulmonary embolism. The late consequence of DVT, particularly of iliofemoral vein, can be a chronic venous insufficiency and ultimately post-thrombotic syndrome as a result of valvular dysfunction in the presence of luminal obstruction and recanalization. So deep vein thrombosis will lead to the destruction of the valve, and this will lead to the chronic venous insufficiency due to incompetence of valve and backflow of the blood, and varicosity. Diagnosis: clinically high index of suspicion. Hormone sign by dorsiflexion of the foot will lead to the pain and should be done very carefully and cautiously to prevent showering or dislodgement of any thrombus into the to avoid pulmonary embolism. Swelling of the foot and calf. Discoloration, phlegmasia alba dolens, phlegmasia cerulean dolens, and venous gangrene. Diagnosis by venography. Venography is an invasive diagnostic tool. Impedance plethysmography, this is non-invasive, and laboratory assay, fibrinogen assay, magnetic resonance venography, also non-invasive technique to assess the patency of the venous system. Prophylaxis, how to prevent DBT. Mechanical methods: leg elevation, early ambulation, intermittent pneumatic compression and graduate compression. stockings أحيانا نستعملها أيضا in case of leg elevation in post-operative or patient at risk. Early ambulation post-operatively. intermittent pneumatic compression نستعمل جواريب خاصة أو استعمال bandage to compress the calf muscle and pushing the blood and prevent stasis. Usage of drug pharmacological agents: low dose unfractionated heparin, low molecular weight heparin, synthetic pentasaccharides, dextran 70 and vitamin K antagonist. Treatment: antithrombotic therapy like unfractionated heparin therapy, low molecular weight heparin, direct thrombin inhibitor, vitamin K antagonist, systemic and catheter directed thrombolysis, IVC filter which used in special condition, operative venous thrombectomy. IVC filter indications: recurrent thromboembolism despite adequate anticoagulation. يعني احنا مستعملين anticoagulant heparin and others ولكن recurrent thromboembolism. DVT in a patient with contraindication to anticoagulation مثل عند peptic ulceration أو liability for CVA hemorrhagic فيستعملون IVC, inferior vena cava أو vena caval filter. Chronic pulmonary embolism, more acute, and resultant pulmonary hypertension, يعني multiple showering emboli, multiple obstruction of pulmonary circulation, and this not response for anticoagulant, so need vena caval filter. Complication of anticoagulation like bleeding and tendency and ulceration. Propagating iliofemoral venous thrombus in anticoagulation, in spite of anticoagulation. Chronic venous insufficiency. Patients complain of leg fatigue, discomfort, heaviness. Sign of chronic venous insufficiency may include varicosity of the vein, edema, hyperpigmentation, dermatosclerosis, and venous ulceration. Importantly, severe chronic venous insufficiency can be present without varicose. A chronic venous ulcer may carry significant negative physical, financial, and psychological implications. Chronic venous insufficiency or post-thrombotic syndrome develop in approximately 50% of the patient with deep venous thrombosis. Non-operative treatment of chronic venous insufficiency: compression therapy, graduate elastic compression stocking, Ona's boot, multi-layered dressing. Ona boot is not a boot, but special bandage used with emollient to decrease the effect of chronic venous insufficiency, which may be associated with dermatological and ulcer manifestation. Surgical treatment of chronic venous insufficiency: perforator vein ligation, venous reconstruction. 3 types of leg ulcer, defined as an area of discontinuity. Definition of ulcer of the surface epithelium. Venous arterial diabetic. Venous ulcer due to hypertension secondary to venous hypertension secondary to DVT or varicose. Ulceration on medial aspect of the leg, above the ankle, any size, shallow, sloping edge, bleeds after minor trauma. There is no occlusion of the artery. Weeps readily, surrounded by pigmentation, associated dermatoliposclerosis. Arterial ulcer, occlusive arterial disease, painful, do not bleed, occlusion of the artery. Non-healing, lateral aspect of the ankle, lateral ankle, or heel, metatarsal heads, tips of the toes. Associated feature of ischemia, example claudication, absent pulses, pallor. Diabetic foot or diabetic ulcer, ischemic or neuropathic. Ischemic, as is arterial ulcer. Neuropathic, deep, painless ulcer, plantar aspect of the foot or toes, associated with cellulitis and deep tissue abscesses due to infection. Warm foot, pulses may be present or absent. Thank you.